Right, so it's 6:31. A couple more people might come and join us, which is great, but we'll get going for those of you who are here on time. And it's lovely to see lots of names joining in. As I just said, please do write in the chat who you are, where you're joining us from. It's lovely to know who else is out there, and for our guest speakers. This is the second in our series of webinars for the summer for the emergency medicine MSc programs at QMUL. So we run for adults primarily, but it does cover peds as well, which is emergency and resuscitation MSc, and then we also have the PEM MSc. And so tonight we're really pleased to be joined by Tessa and Becky, who are the two of the key players in the PEM MSc, and one of their students, Mel. And I'm going to hand over to Tessa to introduce Mel to you all. Just to say, this this webinar is being recorded, so we will be putting it up onto our YouTube channel afterwards, people who can't join us tonight. So just be aware of that, but do put any questions you may have into the chat, and we will open up for a Q&A after the chat as well, after the webinar, so we can ask questions directly as well if you want to do it that way. Sorry, over to you now, Tessa.
Cool, thanks. So welcome everyone. I get the great pleasure of introducing Mel to you, who's going to be delivering the session today. So Mel is a Paediatric Emergency Medicine Registrar at the Royal London Hospital, and she's one of the students on our PEM MSc who has just come to the end of year 2. And she's going to be talking to us today about croup and the evidence base around our management of croup. So Mel, over to you.
Thank you so much for that introduction. I'm just going to start sharing my screen, so hopefully it will work. Perhaps Libby, you can shout out if you can see it. Let me just do that. Can you see it, Libby?
All good. Yep.
Great. Cool. So yeah, as Tessa said, I'm Dr. Melanie Ranaweera. I'm a Paediatric Emergency Medicine Registrar working at the Royal London Hospital. And I've just finished the second year of the PEM Masters with Don't Forget the Bubbles and Queen Mary's University of London. I'd also like to introduce Tessa Davis, who just spoke, who's here tonight, and will be on hand to share any additional thoughts and help in answering any questions you guys might have. So she's a PEM consultant at the Royal London, our Don't Forget the Bubbles guru, and is the program director for the PEM Masters. So when we were trying to think about what to cover in this webinar, we thought it would be useful to go over topics that are very common in pediatric practice, so things that you guys will see as frontline clinicians. So thinking about croup and the latest research around it to kind of guide your management choices, and also thinking about whooping cough as well, because this has become very, very topical recently, because we're seeing lots and lots of rates of whooping cough go up, particularly affecting our pediatric population. So in terms of what I'm going to cover tonight, so a little bit about the PEM Masters. I appreciate some of you are already doing your own Masters, but there are some of you that may not be, and you might be interested in joining our PEM crew. Thinking about the latest management choices in paediatric croup and the evidence base behind it. And also thinking about pertussis and what you guys need to know as frontline clinicians, you know, who are the patients at risk and how are you guys going to manage these patients? And then we can end by, you know, any questions or discussion points that you guys might have. I think Libby and Tessa will keep an eye on the chat if any questions come up, but otherwise we can discuss it towards the end. So a little bit about our Don't Forget the Bubbles and QMUL Masters. And so this is our crew. So 2 of them are here tonight. We have Tessa, who's in charge, and we have Danny and Becky. So Danny's a PEM consultant in Ireland, and we have Becky Platt, who's one of the paediatric ACPs at the Royal London, and they help to lead and run the course. So as part of the course, we also have lots and lots of international leading experts in their fields coming to teach us on the course. So we also have an online question platform called Circle, where all the students contribute evidence-based answers to topics and share their own experiences. And we're quite lucky in our group in that we have a real mix of clinicians, from adult ED doctors to pediatricians to paramedics and also nursing staff as well. So we get a really good mix of viewpoints and experiences from like pre-hospital, in the hospital, etc. We've also got quite an international group as well of clinicians, so people obviously working in England, but also in Ireland and Switzerland as well, and lots of people that have done stints in tropical medicine as well, so sharing ideas from lots of different healthcare systems. So the Masters runs over a 3-year period with a syllabus of topics that are covered in the first 2 years. And then we undertake a project in the 3rd year. So I'm yet about to enter into that. What's been extra exciting about this Masters is not just the Masters itself, but it's all the opportunities that have come beyond it. So with the help of the faculty, a group of students from the year above, so the first lot of students, they have actually developed a Masters writing group, and lots of wonderful projects have come from it. So to date, we've had 2 publications, so one about antibiotics and also one about the use of steroids in croup in children, which I'm going to be covering tonight. We've got one that's coming soon, a paper about pediatric major hemorrhage. And also we've contributed to the bubble wrap, which is on the Don't Forget the Bubbles website, where we critically appraise papers. So if any of you guys have any questions about the Masters, Tessa is more than happy to kind of answer your questions, but also I'd be happy to be contacted as well. So let's get started. Let's start talking about croup. So as a quick reminder to everyone, so what is croup? It's a viral laryngotracheobronchitis, which causes inflammation of the main large breathing structures. So it's typically caused by parainfluenza viruses, but it can be caused by lots of other viruses as well. And interestingly, there's been lots of recent observational studies that have looked at COVID and croup. And actually children that have had COVID related to croup have been older children, which we're not typically used to seeing, and also demonstrate a more severe presentation. So it is very common, and you guys, those of you working in ED, this is a big part of your, it can be a big part of your workload. Affects about 2 to 3% of all children per year. And typically affects children between 6 to 36 months old, and it peaks at 12 to 24 months. But having said that, we do see it in children that are older, as well as, even up to teenagers as well. So it does tend to affect males more. So symptoms typically manifest as coryzal type symptoms, maybe a low-grade fever, a barking seal-like cough, and stridor. So let's meet our friend Bobby. He's our typical croup suspect, 2-year-old that's presented with some snotty nose and has come in today because he's got a bit of a funny, loud cough that's now become stridulous and is demonstrating some tracheal tug. So Bobby is very, very stressed. And more so than him, his parents are even more distressed than he is. So I just want to offer you guys some top tips when you're managing patients with croup. So first of all, croup can be incredibly uncomfortable for the patient. So if you can imagine, it almost feels as if they can't breathe. And croup symptoms typically kick in around nighttime or overnight. So children might go to sleep and feel absolutely fine and suddenly wake up with a sensation of, being unable to breathe. And so that can be really, really distressing for them. And naturally, that can be very distressing for their families to see that as well. So one of the biggest things and one of your biggest roles, even if you're seeing patients pre-hospitally, but also in the hospital, is to really relax everyone and to chill everybody out. And this is one of those situations where I do take extra time to offer TLC to the families, particularly when parents are very stressed, to make it very clear to them, actually, if they're getting very stressed, their child will get stressed, and that's going to make their symptoms even worse. So my top tip is keep everybody calm and start off with some good damage control in the room. The next thing I would say is doing a very good hands-off examination. And by hands-off, I mean, you don't want to stress the child out by, jumping all over them, trying to look at their throat, etc. But you want to observe the child very nicely. So yes, this could be croup, but part of the examination is also to make sure we're not missing any other crucial, important differentials for croup. So for example, if a child has, significant neck swelling or, is actively drooling and looking very toxic and, is incredibly febrile, you might want to think, is this more a bacterial presentation? So thinking about your kind of bacterial tracheitis, your epiglottitis, your retropharyngeal abscesses, or is there any evidence of any kind of lip swelling or tongue swelling with hives? Is this a very allergy prone patient? Because then you would want to be thinking about anaphylaxis. And this is one of those presentations where your paediatric registrar won't force you to do a throat examination. Sometimes we can get quite het up on those good old ENT examinations, but I suppose throat examinations are something we would want to actively avoid, especially if the child is unwell and compromised at that moment in time. So the next top tip I would say is taking a really good history from the family as well. Could there be a history of them having swallowed a foreign body? And you also want to know about the immunization history of the patient, just because if they're unimmunized, they're at risk of having Haemophilus influenza potentially, which is one of the leading causes for epiglottitis. So you want to factor that in as well. So when you guys see your patients with croup, particularly for those of you that perhaps may not have had much experience in managing paediatric patients with croup, what can you use to kind of assess patients, and what can help you? So we have the Wesley Croup score. I don't know if many of you have used it before. So the Wesley Croup score is a useful assessment guide that kind of scores patients with croup according to their level of consciousness, whether they have cyanosis, any evidence of stridor, air entry and retractions, so recessions. So based on the score that you accumulate, it will categorize children into mild, moderate, severe and life-threatening. And there's an associated management plan according to the score that they have. So this is actually a standardized and well-accepted scoring system. So something that you guys can actively use in your management. So a couple of years ago, there was a study done by Yang et al. He undertook a prospective study of just over 200 patients who presented with croup and scored them in accordance with the Wesley Croup score. And the score did have a significantly strong correlation with the length of stay, the management and the course of the child. So patients that had a score of 2 and less on the whole were given steroids and discharged home. Those with more than 5 needed a bit more time in A&E and were given the appropriate management. And those that had a score of 6 and above were admitted to the ward and had ongoing management as an inpatient. So definitely use this, and it's widely accepted. So as most of you probably know, steroids are the mainstay of management in croup, but you will have noticed, particularly those of you that change from hospital to hospital, you know, there's variations in what steroids we give, how much, and the variation can cause somewhat a bit of confusion. So let's go to the evidence, and what is the evidence telling us? So what should we be using? Just to make you guys aware, I won't be focusing on life-threatening croup. So the management of this would be, you know, your nebulized remedies as well as airway interventions, but I'll be more so focusing on children with mild to severe croup. So we do deem croup a self-limiting illness. So are steroids actually required? So a recent Cochrane review was done last year that was published and looked at 45 randomized controlled trials. So yeah, a good number of established trials that took place between 1964 and 2021. And this included just over 5,000 patients. So it only went as far as 2021. So admittedly, it doesn't include children with croup secondary to COVID. And as I mentioned, they have demonstrated a slightly different pattern with it affecting older children and slightly more severe presentations. So in that review, there were 26 studies that looked at steroids versus placebo in the treatment of children with croup. And actually, steroids demonstrated a significant reduction in croup scores between 2 to 12 hours of administration. However, its sustained efficacy at 24 hours was unclear. Also, children that received steroids were less likely to need second-line nebulized treatments or critical care interventions. And those that received steroids had a shorter emergency department length of stay, hospital stay when admitted, and were less likely to be readmitted to the hospital. So anecdotally, in the past, you might have heard of, treating children with steroids and then they go home, and then giving them a second dose to go home with, because children commonly do have repeat sets of, the symptoms do come up again. However, there's no evidence to support sending people home with a second dose of steroids. And actually, it's deemed that this could potentially be unsafe practice, because a child could be in compromise and actually parents are trying to manage this at home. So on the whole, we would advise that, if they're signposting them to what the symptoms are and just telling them to come back if there's any concerns. So what steroids are we all using, and what should we be using? So 13 RCTs from the Cochrane review looked at this and looked at these 6 different steroids, as you can see on this screen. So I guess the main ones that we tend to use are our good old friends dexamethasone and prednisolone. And so beyond dex and pred, the review concluded that more evidence was needed to draw conclusions on effectiveness of the other steroids. So when comparing dex and prednisolone, patients receiving dexamethasone had a lower number of return visits and admissions compared to prednisolone. So the evidence base would support more so using dexamethasone. Interestingly, I suppose in pediatrics, I'm not sure we would do so much of this in adults, but we actually, we really care about a child's willingness to take medications, because if they're going to vomit it up or refuse to take it, then we're not going to get anywhere. So the ability for children to tolerate medications is actually very important. So this was actually undertaken as a study by Alajab et al. Very recently, where they did a prospective study on just over 200 children. And the children received steroids for asthma or croup. So they either received prednisolone tablets, a prednisolone syrup, a dexamethasone solution, or a dexamethasone elixir. And the study demonstrated that dexamethasone was the most palatable option, and prednisolone tablets were associated with the highest incidence of nausea and vomiting. So we would advocate, and the evidence would suggest, dexamethasone, not just for the clinical course of the patient, but it will make children vomit less. So I guess now we've decided we're going to pick dex as our choice of steroid. So how are we going to give this, and what dose are we going to be using? So what does the evidence say about this? So 5 studies in the Cochrane review looked at different routes of administration of dexamethasone. So the options were intramuscular, oral, or nebulized. So there was actually no difference between intramuscular and oral, and they were equally as effective in terms of the children's clinical symptoms, but also in terms of length of stay, admissions, and readmission rates as well. When we compared oral dex or nebulized dex, there was a reduced rate of returns and admissions and readmissions with children having oral dex. So your choices, your intramuscular options or your oral options. So IM dex could be considered if children are unable to take the oral solution, but I'm not sure how many of you have tried to stick an injection in children's legs and see how well they tolerate that. So I would suggest that's probably not the best first line option, and if they can take an oral medication, that would be better, particularly in croup, where you want to keep them as stress-free as possible. But they are equally as effective. So if you're really struggling with your oral options, then you can think about your intramuscular route. So the next thing is, what dose should we be given? So this has been a contentious issue, I think, forever, really, from the start of my pediatric training. What doses should we be giving? So you have 3 options. You have 0.15 per kilo, 0.3 per kilo, or 0.6 per kilo. So the Cochrane review had 4 studies that looked at this, of just over 300 children, comparing the doses. Admittedly, the study does suggest that the data analysis was limited by the heterogeneity of the studies, and there was a significant risk of bias in the individual studies. But what was good about it was they looked at 3 studies looked at children with moderate to severe croup, and 1 looked at mild to moderate croup. So looking at children with a broad spectrum of severity, which is good. So interestingly, the data showed that using 0.6 per kilo had no impact on croup severity at 2 hours, and possibly may have reduced it at 24 hours. However, there's no impact on return visits, readmissions, or length of stay. So the current evidence would suggest that 0.15 per kilo is as effective as the higher dose in terms of outcomes, regardless of the severity of croup. But what I will say is, and a slight caveat is, I suppose when you do see children with life-threatening croup, I mean, it can be very scary for everybody involved. And in terms of, them heading towards intubation, that's going to be a gnarly intubation. That's going to be frightening your anaesthetist as well, potentially. So it's not uncommon for people to then go with a higher dose, I guess, because you want to chuck everything at them as much as possible. So even though the evidence may not massively support that, it does happen. And what I want to make clear is that there's, even with the higher doses, there's no adverse events that have been reported with the higher doses. So I suppose if you do see clinicians using the higher doses, I suppose there aren't any adverse events associated with that. So that's the kind of overview about the latest evidence of steroids and croup. I wonder if anyone has any questions at this point before we move on to thinking about pertussis and whooping cough.
No questions in the chat at the moment, but does anybody want to shout out if they've got a question, or pop it in the chat?
I can't quite see the chat. I don't think I brought it up on my screen, so perhaps
that's right. So yeah, a couple of things there. Sandy's saying we often repeat doses if no improvement after 1 hour.
Sure. Yeah.
Jerome is saying, is there any role for nebulized budesonide?
Yeah, so that actually was looked at in the Cochrane review. I suppose what it looked at was comparing dex and budesonide one-on-one, and actually dexamethasone was deemed better. But definitely, again, in children that we see with acute croup, people end up throwing as much as possible at them. So certainly giving your doses of dex, but certainly as an additional item, you could definitely throw some nebulized budesonide at them. If you're worried about significant compromise, then obviously thinking about your nebulized adrenaline, which you can give in repeated doses as well. And then obviously calling your anesthetic colleagues and ENT colleagues potentially to come support the patient as well. But yeah, there is a role in nebulized budesonide, yeah. And in terms of repeated doses, so I think that, that is difficult, isn't it? Because you don't want to chuck too many steroids at children, and there might need to be a cap on that, I suppose. And in terms of repeated doses, so some would advocate, perhaps 12 hours later once they've been admitted, and you're giving all the additional therapies as well. But I haven't commonly given a repeat dose like an hour later, perhaps. But yeah.
So Sandy's clarified on that. She said, is there any evidence for kids around dexamethasone in the repeated dose? So
as in to give an hour later?
Yeah, I think you're saying no.
I think, I'd have to look into that more specifically. But in terms of what I've routinely done in my practice, I suppose, I guess where I'm working at the moment, we actually give the higher end dose. And so in terms of repeated dose, that's not something we would give immediately an hour later. That's something that you would think about perhaps giving, later down the line. But then you also have all your adjuncts that you can throw at people as well. So it's not just dexamethasone, it's about you can give your nebulized options as well. Your nebulized steroids, your nebulized adrenaline as well. So there's other things you can use in addition to oral dex.
That's great, lovely, thank you. I think we'll let you crack on to pertussis. Yeah,
cool. So thinking about pertussis, so why are we interested in pertussis all of a sudden at the moment? And it is really, really topical because we're seeing high rates of it at the moment. So I guess the approach that I want to take is thinking about what patients we should be worried about and how we should go about managing these patients as frontline clinicians. So what is going on with pertussis and what's it all about? So pertussis is actually an endemic disease in the EU and worldwide. And actually every 3 to 5 years, we do expect an epidemic anyway, even with high vaccine coverage. So it is highly, highly contagious. and is a highly contagious infectious disease, and it can spread very rapidly from person to person and through airborne droplets. So I've actually taken this data from the EU CDC, and if you can have a look, if you see from 2023 to 2024, there is a sudden increment that you guys can see. So just thinking about UK specific data, so in January there were just over 500 cases, and in February, there were just over 900 cases. And in March, there was just over 1,300 cases. And so this is compared to in 2023, where we just had 800 cases or so for the entirety of the year. And why this is really, really important for paediatric practice is because the highest mortality and morbidity we're seeing is in our paediatric population. So your patients under 6 months old, but particularly those that are under 3 months old. And actually, the patient deaths that we have had, so the 5 reported deaths in the last couple of months in the UK have been infant deaths. So that's why it's particularly important for us. So why are we suddenly seeing this increase in pertussis? So it is there is a natural cyclical pattern in pertussis anyway, where it kind of goes up and down, and we're currently hitting the up of that. But that's now in combination with the fact that we are seeing a reduced vaccine uptake in children, and a reduced vaccine uptake in pregnant women as well. And there's a question, as with everything, is this a post-COVID phenomenon? There was very low cases circulating around during the COVID pandemic, and now we're kind of seeing that high at the moment. And also there's a potential theory that perhaps our natural immunity, and with the vaccine, that there's a waning immunity with this anyway. So just to talk a little bit about the UK pertussis vaccine strategy. So I know paediatricians always talk about immunisation schedules, but this is particularly important to understand, also because this is the kind of information you want to draw out from your histories when you're speaking to families, because it actually does play a part in our risk assessment of the patient. So in the UK pertussis vaccine, they should have the 6-in-1. So pertussis is part of the 6-in-1, and they're given that at 8 weeks, 12 weeks, 16 weeks, and there's a preschool booster as well. So if you have a look at that, our patients, younger patients, particularly those under 3 months old, are going to be at the highest risk because they may not be immunized at all, or they're going to be partially immunized. And in fact, some of these children, depending on parental choice, might not be immunized at all. So how do we mitigate that risk for our younger babies? So to mitigate this risk, all pregnant women since 2012 have been offered the pertussis vaccine between 16 to 32 weeks of pregnancy. And it is very effective. So it's 90% effective against confirmed disease in babies, and also 97% protection against death from pertussis. But again, with in children and in pregnant women, we're seeing a decline in people wanting to have the vaccine. So that is part of the what the CDC and the UK Public Health Group are having to look at. And this is part of the strategy about how we can try and improve people having vaccines, and to improve the education to people. So it is multifactorial as to why vaccines people are less wanting to have them. So when you guys are taking your histories from patients in A&E that you think may have pertussis, you want to kind of do a risk stratification, and parents might say, oh, they've had their 8 weeks vaccine or 12 weeks, but actually sometimes parents might pick and choose which ones they want in those vaccines. So be very clear, what vaccines have you had exactly, and asking, mothers and, dads, because they will also hopefully know, did the pregnant mother have the vaccine during their pregnancy. So just to talk a little bit about the pertussis picture. So they call it this kind of 100-day cough, and that's what it's typically called. So it kind of comes in stages. So you can see the first 2 weeks. So just to make it clear, I also borrowed this from the CDC as well, because it's a very nice timeline from the US one. So for the first 2 weeks, so we call this the catarrhal phase, where they kind of have their mild coryzal type symptoms. And this is the point at which patients are highly contagious. So they may not even know that they have it. It might just feel like a cold. And babies, particularly, so when we think about them, this might be the time that, they might be off their feeds, might have some mild coryzal type symptoms, and, they might come to A&E and we think, oh, bronchiolitis potentially. But it can also be associated with them having apneic episodes, as well as a cyanosis with that as well. And then, so after the kind of first 2 weeks, we moved to the paroxysmal stage, where people might have those coughing fits with the characteristic whoop that we all know well. And there might be lots of coughing episodes, and they might be vomiting associated with that coughing as well. So again, your younger patients might present as, not feeding very well. They might be vomiting so much that they need admission for, NG feeds or fluids. And again, just to be clear, in the first week of this period, people are still contagious. If they're able to kind of move past this period, you then go into this kind of recovery stage. So when I say recovery, people can still have a very gnarly cough going on for weeks on end anyway. So it may not be a recovery as such, but they call this the convalescent stage. So as frontline clinicians, we need to think about who's at risk and how do we manage that? And I think that's what's really important for you guys to know. So I've borrowed this from the CDC. So the CDC kind of characterizes risk according to the probability of you catching pertussis, but also the impact that it will have on the individual. So when you look at this, those that are greatest at risk are your less than 6 months old. So this is particularly your less than 3 months olds who may not be immunized or partially immunized. And the reason why, in terms of impact, why we deem them at the highest risk is because they have the highest mortality due to the complications that they can endure, such as pneumonia, apneas, seizures, and encephalopathy. And that risk is very real. In terms of older children, so again, if you have a look at how they're categorized as at being at risk, is actually the probability of them catching it is what's making them more moderate, whereas the impact on them is deemed low. So older children, on the whole, will have a milder course and don't demonstrate the significant complications that we see in the younger infants. And that CDC actually include patients that are unimmunized and partially immunized in that as well when they're kind of doing this risk stratification. So that's what I'm going to focus on mostly, the patients that are, are younger infants, less than 6 months, because those are the ones that we do need to be most worried about. So how do we manage this risk as A&E clinicians or pre-hospital or hospital clinicians? So I think what's important to say, and I think it's something that's not very well known or recognized perhaps, unless one reads into pertussis quite a bit. But one of its biggest considerations is its the mechanism of action of pertussis, and it produces endotoxins that can cause a significant lymphocytosis, so a very high white cell count, predominantly of lymphocytes, that kind of creates this hyperviscosity syndrome. So there's an associated microvascular thrombosis that can lead to pulmonary hypertension, necrotizing bronchiolitis, pneumonia, myocardial dysfunction, and encephalitis. And the risk of that is very real. So perhaps I can just share some of the cases that I've experienced in my clinical practice. So I've seen a few older children during my time in ED with pertussis, and on the whole, they were clinically stable and were okay. And by okay, I mean I do feel bad for them because the coughing can be so bad, but they were otherwise clinically stable. And I've had 2 babies under 6 months old that have had to actually be admitted to PICU because of the complications that they faced. So one was a less than 6 month old when I was working in PICU, who was actually intubated as a possible bronchiolitis from their local centre and sent over to us for the usual kind of ventilation support. And then we had this baby for about 48 hours in our PICU. And this baby's oxygen requirement and ventilation requirement was, going out of control, very high pressures, very high oxygen requirement, and actually ended up being oscillated, for those of you that believe in oscillation in pediatrics. And when we actually had a look at the blood test results, we noticed that there was a significantly rising white cell count, so very high lymphocytosis, and that's when we clocked that actually this wasn't bronchiolitis. This is now, like, it was looking like pertussis, which it was. So the baby needed an exchange transfusion and actually was sent over to another PICU that can do ECMO, but actually they managed to stabilize and didn't end up needing ECMO. The other baby we've had, it was one that I had very recently, a 2-month-old, who came in actually with the characteristic whooping cough, but actually was very stable, feeding okay, but just a bit of coryzal type symptoms. But on the basis of the fact that we thought this was pertussis, we did do their full blood count, and they had a total white cell count of 30, which we then measured 6 hours later, and it actually went up to 50. So the baby had to be admitted to PICU for consideration of an exchange transfusion. So in terms of how you guys should approach these patients, what I would say is obviously undertaking your A to E assessments of the patient. So obviously, if there's any respiratory compromise, you're going to have to manage that. If there's any seizures, again, you're going to have to manage that. But in terms of investigations you want to do, you do want to be doing your full blood counts to see if the white cell count is high. And if it is, then you need to repeat that to monitor the trends. Doing a chest X-ray to look out for any kind of mnemonic changes, if the baby is demonstrating any respiratory features, or if there's increasing oxygen requirement, doing an ECG, looking out for a right heart strain. And then in terms of how do we diagnose pertussis, so this can often be the most stressful part, I think. Which swab do we use? So actually, with the rising cases that we've had, our ID team have actually made that very clear to us as to what we're going to be doing. So hopefully perhaps your ID teams might also be supporting you guys in a similar fashion. So in terms of what tests to do, so that's really dependent on how long your symptoms have been going on for. So if you're kind of within the 2 weeks of coughing period, then your swabs will be useful, and that should hopefully pick up the pertussis bug. So there's a PCR swab and a culture swab. So the PCR swab, I don't know if you guys have seen it, it's a very lanky kind of blue swab, and sometimes it's labeled the pertussis swab, but also your culture swabs as well. If they're kind of 2 to 3 weeks into their symptoms, then doing the swabs, but also thinking about doing blood serology, just because it might be possible that the swabs may not pick up the bug. And certainly if you're going on beyond 3 weeks from when the patient comes from the onset of their symptoms, then the swabs may not pick up anything actually. So thinking about your serology testing. So in terms of how you go about managing these patients, so certainly for the younger age group, having a low threshold for consideration for admission. So the antibiotics that we use are macrolide therapies, so your azithros, your clarithrose, your erythromycins. And what I want to make clear to everybody is if you notice any significant complications in a child that you suspect to have pertussis, so respiratory, neurological, rising white cell counts, and these are the patients that you do want to discuss with your PICU centres if they're retrieval services, etc., if they're not on site. So other considerations that we need to undertake. So we do need to notify Public Health England as part of our strategy in getting on top of pertussis is to try and minimise spread to other people. So this is something Public Health definitely need to know about. So then NICE guidelines and CDC advocate prophylaxis in certain with a certain criteria for those that are exposed. So household contacts, people that are deemed at risk, or people that are going to work with people or be around other people that are at risk. And it's kind of within the first couple of weeks, if you're in contact with the index patient within the first couple of weeks of them being unwell, so up to like 3 weeks from the onset of their symptoms. In terms of vaccination, so, what do we do with those? So you still continue your vaccine schedule. So even if a child has pertussis, they should still continue to be vaccinated against pertussis because of this kind of waning immunity. And the NICE guidelines actually advocate whether we should be thinking about boosters, particularly for patients over 10 years old that haven't had a pertussis vaccine in the last 5 years. So again, the kind of close contacts, high risk patients as well. So you guys might also meet older patients that have, you think have whooping cough, and you give them some antibiotics and they can go home. So can they go back to school? That's a common question that's asked. So as long as they've had antibiotics for 48 hours, they should be able to go to schools. So, not risk infecting other people. But also you might encounter people that don't want antibiotics, in which case then they need to not be in contact with others up until 3 weeks, so the 21 days, and then thereafter they shouldn't be infectious, so can go back to school. So that's the kind of overview on pertussis. And yeah, these are the references that I've used throughout the talk, which you guys can scan on a QR code on your phones. But we can also share the presentation if you guys want. Libby can send it around. And perhaps now we can enter into any questions or discussions. And perhaps you guys might want to share some of the cases that you've had in your clinical practice as well. So I'll just stop sharing now.
Thank you so much, Mel.
Okay.
You put a lot of time and effort into that, and I found it really, really fascinating. I'm going to open it up to the floor and see if anybody's got any questions they want to add and ask. You can either type them into the box, or you can put your hand up and speak if you want to as well. That's absolutely fine. Was very welcome. I know you talked about the kids, and that's obviously your paediatrician and working on that thing, but we're certainly seeing it in adults as well, aren't we, the pertussis?
Yeah.
There's a lot of people of my friends going around going, I've got 30-day cough, I've got 100-day cough, it's been going on forever and ever and ever. I can see Becky nodding her head as well and things like that. When you were looking at your information from the WHO and things, you showed that nice chart of like who's at risk and things like that. Was there anything else specific that came out that you remember from the adult side?
Yes. So in terms of the adults, I thought someone might ask me about this, and I thought, oh, I should bother to read about the adult cohort. But yeah, I guess they again come under that kind of moderate risk. On the whole, like a thrifty adult shouldn't be suffering too many consequences from pertussis. But I suppose they did classify a group of patients that could be at risk. Your kind of immunocompromised patients, your patients with COPD that would already be struck down by some sort of, a respiratory virus or bacteria anyway. So they may need hospital admission in a way that they might need that anyway if they were infected with something, but there's nothing additional that you need to do. Sorry, I did forget to mention for your kind of well patients, in terms of treating with antibiotics, they say, when it's past the 3 weeks of them having symptoms, there's actually no benefit for the patient or for spreading it to others. So beyond 3 weeks, you don't need to give antibiotics.
Feels like quite a long down the line, doesn't it? Still 3 weeks. It's been going on that long. It feels well beyond my normal prescribing habits, and I've certainly been dismissive of people saying there's no point now, and then they've told me they've got better after the antibiotics, and I say, well, that always happens. Even if you've got a virus, you always feel better, don't you? Who knows? There's a question in the group. It's come from Thomas, who's a paramedic on the ENRM MSc. Says, thank you very much. Are either of these patient groups notably likely to deteriorate rapidly? And therefore, is there anything you feel is particularly important for those of us who work in the pre-hospital transfer retrieval arenas to know?
Yeah, I guess in terms of people deteriorating rapidly, I think what I would stress is the most important thing is that people have a recognition of the fact that this could be pertussis and what its potential complications can be, so that we undertake the appropriate measures of admitting them and doing the right blood tests and things. Again, things like lymphocytosis, I feel even in my practice at the moment is something that we're having to share that knowledge around. So I think Thomas, in terms of for yourself, I suppose you would treat this child in the same way that you would treat any kind of acute respiratory pediatric patient, but there are nuances with pertussis that we need to be aware of, and extra special things that we need to do. So I think recognition is really important, and then you support patients in the same fashion that you would with any other kind of respiratory pediatric patient.
Cool. Says excellent. Thank you very much. Indeed. Anybody else? Any other questions they want to put to Mel or to the team? So Nilu says, for older kids who get croup, should they be referred to ENT?
So that's my sister actually, who it's topical because her little one, who's a little bit older, had croup recently, and it was like, what do we do with them? And I think like speaking, I did read about this because it was topical to my family, but also speaking to one of the ENT consultants at the Royal London, I suppose if children are having repeated episodes of croup, he said that there might be some benefit in, ENT teams reviewing them in an outpatient setting to make sure there's no kind of underlying reason why. Maybe they might have like a minor structural change or something that makes them a bit more predisposed. But otherwise, I don't think perhaps doing an outpatient referral might be warranted. But the hope would be that as people get older, they get bigger, things, your airways and everything gets bigger. So hopefully over time it won't be much of an issue.
So it's more about the recurrent cases rather than the individual cases in an older child. Otherwise, we're going to swamp our ENT service.
No, absolutely. Yeah. And I mean, there are certain children that are at more risk, I suppose, children with particular syndromes, or especially, those neonatal patients that have been intubated multiple times and have, stenoses and things with their airways. So there are a cohort of patients that might be at more risk anyway.
Great. Thank you. Any final questions? Tess, I was thinking, Tess and Becky, you haven't been in so much recently. Whether are you seeing a massive increase in your caseload at the moment, Mel?
Oh, what, pertussis or croup?
Yeah,
or
both.
Oh, actually, what we're seeing, so I'm seeing more pertussis, but we're also seeing a lot of measles as well. So that's one for everyone to read about as well and to be aware of. Measles, like it has definitely made as we're all aware, there's an outbreak at the moment. So that's something to be aware of as well.
And I think, Becky, are you still on the outlook for good pictures of measles in different skin tones as well?
Yes, very much so. If anyone spots a case of measles and would like to upload it to dftbskindeep.com via the submit your photo link, I'd be very grateful. You can get the parent to take the photo on their phone and they can just upload it directly from there. And I would love you forever if you do that. The other thing, just on the pertussis note, I was doing the results checking at work this afternoon and I picked up 2 cases of pertussis.
Oh, wow.
In that results checking. So it's definitely out there.
Brilliant. Thank you. Pem, I mean, Mel gave us a lovely, thank you so much, Mel, for talking to us about croup and about pertussis and bringing in the relevance of that. And we really appreciate it. It's really useful for us all to have this update. And this recording will go live onto our YouTube site and we'll share it out with other people who've registered. You can share it with your colleagues as well, so people can watch it again and go through that details. And thank you also very much for the comprehensive reference list, which is fantastic. And the QR link works perfectly. I just tested it. Okay. You did a lovely promo for the PEM MSc at the start of the talk as well, which was great. And I just wondered if Tessa or Becky, if either of you wanted to add anything or say anything else about the PEM MSc that we run from Queen Mary's University.
I think Mel's given us a very good overview of what we do. We try to do it in a slightly different way, maybe from the way some other courses run. So it's more about more asynchronous learning, but more about community building. And tailoring your learning to what works for you in the environment you're in the country you're in, or the area of the hospital, or the country that you're in. And yeah, we're happy to answer any questions if anyone's got any questions about it.
So the link's been put in the chat by David. So if anybody wants to go on the link for the PEM MSc, it is there. Does anybody have any questions for Tessa or Becky about the MSc that they'd like to ask? Good chance. Thanks for joining us from Austria, Christoph. That was great. If there's no questions about the PEM-MSc, also just for those of you who work more in an adult sphere or want to look at sort of more broadly, then we also run an adult emergency and resuscitation MSc from Queen Mary's University London. So it's a Russell Group university, but it's a completely online and distance learning program. It's spread out over 3 years because practically everybody who's on the program, including a couple of the people on the call tonight for sure, you know, working full time at the same time as doing this, or maybe working at 80%. So it's run with sort of 4 modules per year for 2 years, and there's asynchronous lectures and podcasts and other content to look at, and then weekly face-to-face tutorials online. So we have people joining us from the UK, but also from across Europe, from Africa, from the Indian subcontinent, and currently also from the US and from the West Indies, which is fantastic. And you do that over 2 years, and then the 3rd year is a dissertation where you get to look more deeply into a topic of your interest, and explore that and get supervised through that process. The idea is to produce really fantastic educators and academics and clinicians across the specialties of medicine and nursing and paramedicine as well. So we have a mixed interprofessional group of students, and we're working on increasing the interprofessionality of the lecturer team as well. But we do have worldwide experts joining us on that, so it's fantastic. Again, the link for that is in the chat. If you want to find out more about it, do go on there. You'll see some videos from me and from other people, and it'll tell you a bit more about that program. But other than that, I think I'm going to say thank you very much for everybody joining us tonight. Thank you, David, for organising and keeping us all in check. Thank you, Mel, for that fantastic presentation. For Becky and Tessa for being here and running a fantastic programme, and getting these wonderful publications and other work happening in collaboration with DFTB. And for all of you for joining us from around the world, it's really great to have had you here. So thank you very much. Good night.